to all my patients and their families, because they are our best teachers. This is a brief introduction, which will go on record in the session. I just wanted it to be there, and I think Saeed has gone over all the details that I have written here. So this is a brief CV, and this is a brief introduction that I have. Saeed also mentioned, thankfully, all the units that I have worked so far. Basically, when I returned to Pakistan in 2002, neonatology was a relatively new concept. It was not an absolutely new concept, but it was a relatively new concept. And I got a chance to initiate and establish many neonatal services as well as pediatric services. And I thank Allah for this opportunity that I got for in my province, in my city, and in my country. The references that I'm going to be quoting today are going to come with the sections that I'm discussing. I see the list of references at the end of lectures, and maybe I have attention deficit. I really don't make much out of them. So I like including references where the subject matter is being quoted. This is Dr. Volpe. I think he's 86 years old now, maybe 84. I'm not sure. He's in Harvard, and he is the founder of neonatology. So I had to mention him here. The textbook that he wrote remains one of the most robust references and is updated annually. And he is involved in the practice of neonatal neurology. And I consider him my teacher in this field. He is a teacher to so many. Very briefly, I'm going to go over how I tackle most subject matters, because as I was discussing with Saeed just before we started, that the topic of brain development, or for any part, any section in neonatology, evaluation and management to be handled in the same session it's very difficult. I don't say it's impossible. Maybe many colleagues have done it, many seniors have done it, but for me, it's very, very difficult. So the approach that I'm using is that I'm describing the problem today. However, we describe the problems to solve them. Just a description of the problem is not going to help anyone. So basically, what we do when we tackle any topic, when we tackle any, sorry about that. So basically, we describe that what is the problem. I believe that if we describe what are the main components of the problem, it helps us tremendously towards achieving a solution. Then we describe why or where does the problem occur, or so to say, the epidemiologic inquiry, the causative agents, etiologies. But when we're looking for a solution, the important question is, where can we intervene to prevent the problem? Those are colleagues who are, and seniors who are on the neonatology group, know very well that we are in a very robust debate these days about cooling, cooling neonates to prevent brain injury. And there are proponents and there are opponents, and I am enjoying it tremendously. And I think that this shows that almost all of us have the same approach. Where can we intervene to prevent the problem? If the problem is so big that the resources required are out of our means, then we need to focus on prevention. And of course, in the end, all of us need to know what are the outcomes of any problem. Well, what are the red flags that prompt towards the problem? And this helps us to recognize the problem better and to plan for the subsections and the little pockets of population that we want to address if we want to address the problem effectively. Now, when we think about organizing a solution, which is the ultimate aim in any academic discourse or any clinical interaction. Like I said, that what are the main components of the problem? Where can we intervene to prevent the problem? And what are the red flags that prompt towards the problem? I take an upside down approach, and I teach, and I like to think about and I deal with the red flags that prompt us towards the problem. See, there is a concept in reverse engineering where you look at a component and you can build it from scratch. They have their own principles. Engineering education is very different from medical education because they make things and we deal with something that Allah made. So there is a basic difference of the philosophy. But what are the red flags? Of course, then where can we intervene to prevent happening of those red flags, happening of those problems? And then, of course, what are the main components of the problem? Because we deal with populations, we deal with patients, we deal with babies. Uh, and no baby will tell us, and no ultrasound probe will tell us that this baby is going to have a brain problem. I'm talking about general population here. Okay. So when we say that we want to approach towards plausible solutions, like you say, evaluation and management, so the thought process behind this lecture series also is to look for plausible solutions. What are the red flags that prompt us towards the problem of brain damage in neonates or brain damage in the premature neonate? Premature babies happening anywhere, intraventricular hemorrhage, fits, post-hemorrhagic ventricular dilatation, CP, cerebral palsy, learning and behavioral disabilities are the red flags in population that prompt us towards the fact that a problem is occurring at some point in the lifetime, in the existence of that patient. Now, where can we intervene to prevent the problem? And coming from Pakistan, this is where we face the dilemma. There are vast arenas of maternal health, of neonatal care, of school services for the children, services for special children, physiotherapy, nutrition. This is where the magic happens, I should say. And to say what are the main components of the problem, we know very well that it's sick mothers and premature babies. And in today's talk, I'm going to be focusing on this approach towards a plausible solution. Now, here are the objectives of my talk. And these objectives span both the talks. So I think I'll be dealing with maybe only the first objective today, or maybe part of the second objective. The second talk is going to be about diagnosis, evaluation, follow-up, important clinical pointers. Today, basically, if we want to approach the problem of brain damage in premature neonates, I think the first step, the first skill to learn is to correlate patterns of neurologic deficit with the timing of insult at specific stages in fetal development. I'm not sure if any colleagues from OB-GYN are listening, but I believe and I hope that these talks do get shared with our esteemed colleagues in obstetrics, because, there is a, what should I say, there's a lack of communication between us neonatologists who deal with the product of conception and those who are managing the product of conception for the 9 months of its existence. Is somebody trying to talk? If there is a question, I'll take questions at the end. It's my advice is to keep your microphones off because recording is in progress. Okay. There are so many stages in neonatal brain development where damage can occur. And in the end, to say that just because the baby was born premature, just because it came out premature, and just because a cesarean section was not done in time, or just because a cesarean section was done, it's not about the differences that we have. I think we need to come together on avenues of similarities, and the development as you know it, and the development that we face in the end, we need to come together to a consensus and work together for prevention of this calamity, this something that is a catastrophe for the whole family. And then to develop an organized approach towards recognition and management of neurologic injury in the preterm neonate. And of course, because I am an affective domain teacher, I teach behavior change, and I teach interaction at the level of concepts and behaviors. So to say that, addressing the aqidah of our families, because the baby is going to go back to them, and the entire life and outcome, prognosis, progress, even success of that baby, for that matter, depends on that family. So, how to counsel the parents of a preterm neonate about what to expect for their baby's future, the resources that are available, and what kind of help to seek in this situation. Now, scope of the problem, and as you can see, I've written the reference right at the bottom here. Some of the references may be old. I've gone, in my literature search is extensive, maybe because of my age, but I have gone far back in the history of the problem. This is from a textbook that I showed you in the beginning. The importance of encephalopathy in this large group is indicated by the subsequent occurrence. So the most important thing, why are we learning things like oligodendrocytes and oligodendroglia and exons and myelination at my age? It's painful. But the importance of encephalopathy in this large group is indicated by subsequent occurrence of cognitive, behavioral, attentional, or socialization deficits in 25 to 50%, and of major motor deficits, that is cerebral palsy, in 5 to 10%. Now, this is US data. This is US data back in 2008. I'm going to show you some Pakistani data in the end, but this is a textbook of pediatric neurology, and it defines the scope very well. We're dealing with disability. So this is something to keep in mind when we say a premature baby with brain damage, with problems. And this is again Professor Volpe. The several references used in making this statement are also given here. These are very worthwhile articles. All of you are welcome to, and most of them are available. They are easily available. There were only 1 or 2 articles that I had to request a library to get for me. Now, the crux of the problem is because of the sharply increased survival, and the same thing is, this is true of UK, this is true of US, this is true of Pakistan and India. Because of the sharply increased survival, 50 to 70% in recent years, these extremely premature infants comprise a substantial proportion of infants. And then, in very low birth weight in many centers, disability in this subset exceeds 50%. So if 1 in 2 babies are suffering from disability, this is something that needs our attention, first and foremost. Again, this is 2007 where, the paper is taken from, but the situation in Pakistan is only worse, has not improved, if anything. Now, the first objective that I shared with you is correlating of patterns of neurologic deficit with timing of insult. Now, for those young people who are listening here, I don't know how many trainees or how many young consultants are listening. The amount of research that is done and is being done is out of this world. I mean, it is fascinating, and I would urge you to follow. Now, this picture, I think, if I remember correctly, I do have a reference for this. This is taken from Nature. Nature is a journal that is not about neonatology, that is not about neurology. But this is from Nature, and there's a special series of articles about brain. And this shows a research. If you look at the bottom here, this says organoids, and then it says human brain development. And then it shows a timeline up to 40 weeks, the first trimester, the second trimester, and the third trimester. And here in the organoid stage, it shows a petri dish where stem cells or special, I'm sorry, I need to go back. Or special cells are stimulated to grow into brain cells. However, we are only able to replicate that development up until the fourth month. We are unable to do that, to replicate the development any further. And it shows that we are successful in developing neuroepithelium, the cortical wall, and some similarities. But if you see this, see it says similar in the purple color. So up until maybe 16 weeks, we have many structures that we are able to grow in a lab and study. However, the similarity index goes down from there on. So this is just to give you an idea of the amount of work that is going into brain research of the premature babies. I did my fellowship back in 2001. And I remember working on autopsy specimens of neonatal brains. So that was the state of research at that time. Those in Pakistan, this is something that we need, and this is something that we need to follow, at least if it is not happening in our own beloved country. Most notable neuropathology in the preterm neonate is periventricular leukomalacia. And the second part of my lecture, where I talk about diagnosis and follow-up, is going to be about PVL. There are many other patterns that you will see just now, but this is it. Okay. Most notable neuropathology is periventricular leukomalacia. It is accompanied by neuronal and axonal deficits that involve the cerebral white matter, thalamus, basal ganglia, cerebral cortex, brainstem, and the cerebellum. Okay. Famous picture. This is from a review by Professor Volpe. It is easily available. If you want me to send it, I'll send it in the group in neonatology. But it's available on Google. And I think it takes the correct format of searching, and it comes right out. So gliosis is the process of fibrosis that is the result of brain damage. Now, there is a decreased volume, decreased anisotropy. If you see that 20 to 30% of gliosis, and then 60% of gliosis that you see is in the periventricular areas, the dark gray sort of picture here. Thalamus, globus pallidus, and putamen are shown here very clearly. And then if you see right at the bottom of the picture is inferior olivary nucleus here. 90% of PBL occurs in this area. I don't know how many of you knew this before, but I'm glad that you know it now. Again, I've taken this from Volpe's Neurobiology, which is an older textbook. This is an older article that came out in pediatrics. And it shows the difference. There is a diffuse periventricular leukomalacia. And then there is focal, and there is a relationship between the different blood supplies that different parts of the brain gets. And another complexity that is introduced here is because of the developing brain and the pattern of blood supply in that developing brain that leads to the propensity of diffuse PVL versus focal PVL to develop in different areas. Now, this is to show you some other lesions that happen. Remember, periventricular, if you know periventricular leukomalacia, you're good enough. You're fine, okay? But there may be a severe germinal matrix hemorrhage with intraventricular hemorrhage. The GMH IVH complex that you see written happens, particularly with periventricular hemorrhagic infarction. Now, PHI is something that this again may come as an anecdote. This is what I've seen a lot in Pakistan. And the reason will become clear as we progress in our discussion. The reason is that we, in Pakistan, there are so many of the disturbances that are easily prevented in the West, that are easily prevented in more developed setups that are still happening in Pakistan. And that is why we see a lot of hemorrhagic infarctions. And periventricular hemorrhagic infarction is a very important lesion with disastrous, catastrophic effects. And it happens in the tiniest of the babies. But it's, well, they say it's quantitatively less common. We don't have research in Pakistan to tell us. Maybe it is quantitatively more common in Pakistan. But again, don't take it from me. It needs to come out in statistics. A very important figure, and I'm going to show it to you separately as well. Now, this says that severe germinal matrix hemorrhage occurs in about 5% of preterm neonates. There is a study from Pakistan that quotes more than 12% of their total outcome. So we have reference from Pakistan to say that we have more IVH compared to studies from the developed countries. Importantly, the occurrence of post-hemorrhagic infarction can rise to 20 to 30% in infants below 750 grams. The limit of viability in Pakistan in government setup is 950 grams. In semi-private setups is 850 to 900 grams. In the best of setups, which is Aga Khan and Indus, and some other privately owned, maybe Shifa. I'm not sure about their figures, but we need to come out with publications from them about lower limits of viability. The PPA Neo chapter, I could not find their recommendations about the lower limit of viability in Pakistan. This says 750 grams. And the reason I will explain as I progress in the lecture that why the tiniest of the babies suffer from infarctions and more IVH compared with babies who are a little advanced in their gestation and have a better body weight. Periventricular leukomalacia and then diffuse white matter injury, which is diffuse white matter gliosis, DWMG written here. Is shown, and then different parts of the brain are shown, and the extent of injury is also shown here. Let me just show you a better diagram here. So periventricular leukomalacia, if you see the most common region where common regions are basically, see you here, thalamus, globus pallidus, hippocampus, these are the most sensitive areas. And looking at the pattern of neuronal loss, it is very easy to correlate with the type of outcome that we face in these children. Horrific learning disabilities, behavior problems, sleep induction problems, anorexia, memory issues. They cannot go on with a normal school where rote memorization is part of the academic curriculum. Shape recognition, spatial orientation, all of these things are disturbed in these children. Then diffuse white matter gliosis, fortunately, does not affect a lot of the major structures in the brain. It spares, because there may be subtle deficits, but diffuse white matter gliosis is common in the region of cerebellum, then also in the periventricular areas, just under the ventricles of the brain, and this leads more to issues like coordination, like gait, like equilibrium of the body, conjugate gaze. These are the outcomes that come out of damage to this part of the brain. Now, I included this study to give you an idea about how old the interest in neonatal brain is. This is an article from 1974, and it is now considered a classic study, which is vulnerability of the developing brain and some lasting effects of X-ray irradiation came out in neurology in 1970. The concept of enhanced vulnerability of rapidly developing events during brain maturation was postulated and corroborated by the classic studies of effects of infantile undernutrition. So a multi-pronged approach is used. It is, it's nutrition, exposure to X-rays, state of development of the brain, even maternal nutrition. And, this postulate came out that it has multiple angles. It's not just one simple problem when we talk about the brain damage or brain injury in the premature neonate. Now, why is the cerebral white matter so prone to injury? There is an incomplete state of development of the vascular supply. Okay. Then maturation dependent impairment, which means that the brain is not mature enough in regulation of cerebral blood flow. Now, this is something that I want to share right here and now. You know how we receive the babies, and especially in government setups, and we give them rapid infusions of either dextrose or normal saline. And if they are in a phase where cerebral autoregulation is not on, the rapid change of blood pressure in the cerebral vasculature can easily give rise to intraventricular hemorrhage, to a germinal matrix hemorrhage, to a hemorrhagic infarction. Um, and that, to me, I think it'll take, I don't know how long it will take to prove, but to me is one of the major reasons that we see more IVH in Pakistan, or in developing world compared with the developed world. Then maturation, development, vulnerability of the precursor cell, oligodendroglial precursor cell, that represents the major cellular target in PBL. Periventricular leukomalacia happens in these cells, and there is a maturation dependent vulnerability. There is a free oxygen radical damage theory. It's not a theory anymore, it's well proven. It's the rapid shifts in the blood pressure of the baby and anoxic injury. That is a complex that gives rise to, first and foremost, to periventricular leukomalacia, to neuronal damage that then leads to periventricular leukomalacia. Going down to the cellular mechanism, I did not want to leave any base uncovered. Before I go into evaluating these babies, we must understand. And we as neonatologists, pediatricians, and as obstetricians must understand that the brain cells of a neonate or a fetus are exquisitely vulnerable to attack by free radicals known to be generated in abundance with ischemia and reperfusion. So you see, and in our government setup, sometimes we don't even have the facility to monitor oxygen saturation all the time. Sending blood gases to remote sites and getting the results in half an hour to 40 minutes. is a major contributor in occurrence of brain injury, maybe even in full-term babies. Here we are talking about preterm neonates. The vulnerability of the oligodendroglaya is maturation dependent, and they are highly sensitive, while the mature oligodendroglaya are resistant. And the result is generation of a deadly reactive oxygen species, and as a result, apoptosis, or the cell death of the oligodendroglaya, that leads to periventricular leukomalacia. It is shown very well here. It is from the same article in 2001. This is an article then came out in Pediatrics, as well as this was discussed extensively in the article in Nature. So it's a multi-pronged approach in prematurity, maternal fetal infection, prematurity that leads to, maternal fetal infection may give rise to cytokines and macrophages, microglia. Tumor necrosis factor alpha, interleukin 1, interleukin 6 are well-known progenitors of cell injury in this case. Ischemia reperfusion with hypoxia, with sudden closure of the PDA, with increased concentrations of oxygen, and then suddenly a decreased concentration, leading to vasodilation and vasoconstriction, unchecked. And then, of course, the volume and the speed of infusion that we give to the baby all give rise to reactive oxygen species. Now, there is a role for increased iron, and the problem, this, is very easy to understand. If there's a bleed, there's a lot of iron available in the vicinity. Then antioxidant defenses are not developed in a premature brain, and the presence of glutamate. Now, the reason I'm going so much into this is so many of the new approaches to prevention of brain injury in the preterm neonate are focused on these target points. The reactive oxygen species give rise to oligodendroglial death, like I mentioned. It's apoptosis. The cells commit suicide, thinking that there's no point in living anymore. Prevention strategies, like I said right in the beginning, and this is, I think, to me, this is one of the most important slides of my talk today. Avoidance of cerebral ischemia. By detection of infants with impaired cerebrovascular autoregulation with NAIRS, or near infrared spectroscopy. This is out of the question in Pakistan, I know that. However, it is done in best of the best centers. I worked with it in McGee Women's in Pittsburgh. But, just to say that at least avoidance of cerebral ischemia and avoidance of ischemia and avoidance of hyperoxygenating are all target points if we want to tackle the problem effectively. Free radical scavengers to prevent toxicity, and one of them is vitamin E. The other one that is mentioned here is still experimental, and it is available and it is under study. And then maternal antibiotics and anti-cytokine agents to prevent toxicity from maternal fetal infection or inflammation, and cytokines. Let me see if I had anything else in the prevention strategies. Yeah, okay. So I've covered maternal antibiotics, baby antibiotics, anti-cytokine agents. Now, indomethacin was studied, I don't know in the hope of what. It's an anti-inflammatory, but there are no conclusive results. In fact, there are no results. So indomethacin is out as as a preventive strategy to prevent brain damage in premature neonates. Free radical scavengers, especially vitamin E, needs to be focused on and followed and studied. And for my colleagues and juniors in Pakistan, this is an area of research that you can undertake de novo. There are very few avenues of research available to us, in the presence of giants like Professor Volpe and these massive, research funded by the NIH. But use of vitamin E to prevent brain damage or to improve neuro outcomes in premature neonates is something that can be studied, that is very much doable, that should not have an ethical impetus on it. It's already under trial and it is already being used. So we can do studies to show the effects. We don't have any deficiency of babies or population, and it's very much doable. Now, avoidance of factors that may lead to cerebral ischemia, even in the presence of intact autoregulation. This is important in our babies. I mean, our babies are not 750 grams. 750-gram babies are declared as abortuses. So we have babies that are at least 900 grams, that are at least 850, 950 grams. And these babies are into their, they're beyond the 27th to 28th week of gestation. They have an intact cerebral autoregulation, but we must prevent severe hypotension or marked hypocarbia. Hypotension occurs all the time. We are rushing and we are yelling for normal saline boluses and we are yelling for dopamine and dobutamine and pressor support. If anybody's listening here from Lady Reading, they will know, and they will also know why I'm smiling. Then moderate hypoxemia, marked hypercarbia, all of these factors we can avoid, and they are contributing towards a better neuro outcome. If we can save a brain by doing such tiny things, agents that may act at multiple sites are administered antenatally and have been suggested to be beneficial in prevention of PVL. They include max sulfate and glucocorticoids. Max sulfate is advocated. Yes, it has a lot of benefit. If anybody's listening from obstetrics, yeah, you guys are doing a good job. Your research shows, and our research shows. In fact, our collective research shows that max sulfate is effective in prevention of periventricular leukomalacia. Glucocorticoids is a little different. The story of glucocorticoids had an amazing, up a peak. Everybody was giving glucocorticoids and is still giving, and we were loving them and we were happy. And we were even giving them to the babies. However, extensive research, finally reviews, have shown that enthusiasm for antenatal glucocorticoids must be tempered by the recent demonstration of deleterious cerebral effects of antenatal dexamethasone, but not betamethasone. So betamethasone is safe. Dexamethasone, the decadron, so-called decadron that we do in Pakistan, is not safe. Betamethasone is safe. And then postnatal dexamethasone, again, the decadron that we like to give, is not safe at all and has been shown repeatedly, multiple researches, and I have included all of them in the lecture. So, those of you who are interested, and I hope many of you are interested, can go and go over these researches yourself to see what the literature has to say. Now, I'm going to go briefly over 3 studies that I selected out of a long list of studies from Pakistan. This is a relatively a moderate-sized study, I should say, by Uzma Afzal et al. It came out in Rawal Medical Journal in 2009. They had 163 neonates, and they had a mortality of 46%. So, if I forgot to tell you in the beginning, the reason I'm a neonatologist is, this reason is unfortunately going to go with me to my grave, maybe, that Pakistan holds the highest ranking among developing countries for maternal mortality rate, for neonatal mortality, and for infant mortality rate. Doesn't matter what the statistics tell you. Doesn't matter at all. Do not take it at the face value. We are top of the list among developing countries. We are top of the list in SARC region. We are top of the list in EMRO. And this is a fact. Our collective failure as a specialty for neonatology, our collective failure as pediatricians, and as a nation, because only doctors cannot be blamed. There are systems, there are checkpoints. But anyway, so here is a study in literature that says the neurodevelopmental outcomes for very low birth weight and extremely low birth weight infants. And they say that 46.6% expired. This is a long-term follow-up. Only 87 babies out of these 163 survived. And this is a good center. They're publishing, they're working hard. So 87 babies lived, and some were lost to follow up. In lady reading, we have 95% lost to follow up. It's a small study that I did. The most commonly encountered neurodevelopmental sequelae was motor delay. That is 33%. Cerebral palsy or spastic diplegia, 16%. Recurrent or acute respiratory infections, 24%. Speech deficits, 9%. Hearing deficit, 4.5%. And seizures, 6%. This is a study out of Pakistan. This is original literature. This is a very well done study, and they did an excellent job. Then risk factors for intraventricular hemorrhage in preterm infants from a tertiary care hospital. And I think this is Aga Khan. I'm sorry, I'm missing, or maybe I didn't check. This came out in JPMA, a very good journal, and it came out of Karachi. So there were 201 preterm neonates, again, a moderate size study, a good study. The incidence of IVH was 22.1 per thousand live births. And then they have calculated odds ratios, which put me off a little, because is this a prospective study? Is this a retrospective study? If this is prospective, then we can calculate the incidence. But if this is retrospective, because they're doing odds ratio, then we cannot calculate the incidence. However, it is still data. Now, their study said that the highest, the odds of developing IVH was the highest in babies who got mechanical ventilation and in babies who got surfactant. This is a standard finding, well corroborated by literature. Yeah, giving of surfactant with a sudden decrease in the in the pulmonary vascular resistance and the pooling of blood in the lungs does have a deleterious effect on immature vasculature of the premature neonate. Here again, the mortality rate is 56.7, but this is premature babies, low birth weight, and extremely low birth weight. And finally, this is a study that was called Purpose. This came out in Lancet Global Health. It's big deal. Okay, this is a big deal. And it was done for 2 years. The study was funded by Bill and Melinda Gates Foundation. It is a very well done study, and cohorts were taken from Pakistan and India. And in these 2 years, 3,470 babies were enrolled. 23% died by 28 days. And of those, 615 were eligible to be enrolled, and they were enrolled. Maternal causes were hypertensive disease, followed by maternal complications of pregnancy and preterm labor. No complication is highlighted. What was the complication? But it is maternal complications. Primary placental causes were maternal and fetal vascular malperfusion. And once again, this is sort of related to the hypertensive complication in the mother, and chorioamnionitis or phenocitis. Primary neonatal cause of death was intrauterine hypoxia, followed by congenital infections, neonatal infections, and respiratory distress syndrome. The reason I included purpose here is that this is sort of the concrete data that we have available in Pakistan. We need to go way beyond this quality of data to tackle brain damage in premature neonates. But this is the literature that we have available in Pakistan. I believe this is all I needed to cover in this session. Thank you for your presence, your attention, your dedication, and of course for your patience. Thank you very much. I'm here if there are questions or other points to be discussed.
Thank you so much, madam. Any question from participant and senior respected teachers?
Sure. Thank you, Aksha. Thank you very much. There are 2-3 points, if you can clarify. The prevention of IVH. First of all, what are the viability, age of viability? In our country, the age of viability should be above 1,000 grams. Okay, so because of many reasons. Now, the prevention, you told us about a few things. What about the other things in your mind that we can implement easily in the low resources thing? Okay, steroids is the one thing, magnesium sulfate is the another thing. What else we can do to minimize the brain injury or brain damage? In your opinion, just for the our fellows and the consultant, and for us also, that what else we can do or help our people to minimize those injuries, other than those 2-3 which you mentioned?
I think the focus of prevention is at the obstetric end is actually the prevention of premature labor. But having worked in a very busy obstetric setting in Peshawar, I think the busiest, I don't blame my obstetric colleagues for dealing with the kind of emergencies that they do, and for dealing, for giving us those premature babies, because the cases come so far advanced. However, teaching about prevention of premature labor, better maternal nutrition is one thing. Then, at the level of the neonatal service, all the people who are working in a neonatal service, and at any given time, there are at least 100 medics involved in a government neonatal setup. I can tell you that much. This is true of Lady Reading. Must be trained in neonatal resuscitation, and neonatal resuscitation that is homegrown in Pakistan. It must not be a neonatal advanced life support course that I did in US, because that is completely different. We need homegrown education for our fellows, our nurses, and our medics who are dealing with premature babies, first of all, to prevent the kind of resuscitation that is going on. Even the movement of the head of the baby, positioning of the head of the baby, giving oxygen, pulse oximetry, when to send the first blood gas, how much fluid to give, and what fluid to give. All of that needs to be taken into account at a platform that can address the whole nation, and recommendations need to be made about proper neonatal resuscitation.
Okay. Naveed, you want to say something? Go ahead. Okay, that's fine. But the problem is that, you are working in that setup and the people are not listening. So myself, actually, I have a very small contribution, but Professor Khalid Haq and Dr. Professor Irfan, we actually modify the resuscitation, but still the people are doing the NRP. So I don't know how to tackle this thing. It is published at the PPA side, and the people are still doing their own things, and many of them is not recertifying in the resuscitation. So resuscitation. So the problem is this, that the prevention you can tell, but the people are not either understanding or taking it seriously because this thing. The next thing is that you mentioned about this study, which you said is a very high impact or a big deal. So what is the big deal about that? I don't understand. They just show us that how much is the mortality, how much is this thing. So what is the new thing in that study?
The reason I shared this study is for my colleagues to see that the highest amount of funding and the highest level of publication, and look at the type of data that we are providing. Exactly. Thank you so much for pointing out what is so special about this study. There is so much funding that went into this. Somebody applied for a grant to Bill and Melinda Gates Foundation. There is so much that could have been done with this grant. There is so much that could have come out from this kind of funding. And this is the information that we are providing to a high caliber publication like Lancet. I just want us to realize as professionals at the level that we are, before we even begin tackling questions like why and how of brain damage in premature neonates. So thank you so much for pointing out.
Okay. There are a few more things, but I am just asking other people if not, then of course the other thing is that when the baby delivered, you know that the risk of this thing, I'm not worried about less than 27 weeker in our home country, because really it is a burden on the system, and we shouldn't. To me, I mean, we shouldn't resuscitate less than 27 weeks. Okay, but if you go by Quran, it is also the viability is 26 plus weeks. And if you go by the lunar months, it is about 27 weeks and plus. But the thing is that the brain injury, the IVH, okay, it can happen up to 32 weeks. Can happen up to 34 weeks. So in those big babies, what you suggest, because those are viable babies actually, any part of the world. So what you suggest, let's say the 33 weeker, what you suggest that it deliver, and what you suggest to that how we prevent these things.
So as soon as the 33 weeker is received in the unit, it should be received by somebody who is well trained in resuscitating premature babies, and their training should be current. Then the next step is that the baby should have a space in the unit, which is for 33-week babies. It should have a working incubator. It should have an infusion pump. It should have a continuous monitoring. And it should have the presence of a doctor and a qualified nurse in a ratio of 1:2 or 1:3. And after that, if you're asking about therapeutic interventions, it's like I said, it's vitamin E. It's to see if the mother received MEC sulfate. It is to explore the possibility of using steroids if possible. It is to make the availability of a cranial ultrasound available by the bedside that can be done in a sterile manner. And it is to monitor the baby round the clock for any adverse neurologic events. It is to measure the blood glucose and the electrolytes of the baby round the clock, once or twice in a day at least, in a reliable manner. That is where we at least begin and start thinking about the possibility of neuroprotection.
Maqbul is asking some question. Maqbul, go ahead and mute yourself. Maqbul?
Yeah, hi, Assalamualaikum. Can you hear me?
Yeah.
Yeah, thank you very much for a very nice talk and overview, and some nice studies that has recently presented this purpose study. I need to look in go into the Lancet and find out. Just a few comments, you made about we should not be using this structured neonatal resuscitation in Pakistan and should have a homegrown. I'm a little puzzled, what do you mean by the homegrown for our setup? If you look at the basics of basics, because I was involved in HBB, development of HBB, and HBB does not even have oxygen, does not even have cardiac compression. It just had ambu bag, and that you can easily apply in any setup which are resource limited. My second question is about, you mentioned something about pushing fluids and the rate they were pushed and so on and so forth. If we are doing, I know it's part of neonatal resuscitation, but is at the very, very bottom of the bottom of neonatal resuscitation. I don't remember in my last 10 years or even 20 years that I've even pushed normal saline in any unit during resuscitation. So that should be the last of the last resources. I mean, if we take care of ABCs, that will take care of 99% of your resuscitation, even down to 22 weeks, 23 weeks. So these are my just two comments. If you can elaborate on it. Thank you.
Sir, Sajjad is want to say something. Ji, sir, can you hear me, sir?
Yes, I can.
Ji, sir.
Yeah, thank you very much. And I just wanted to say a lot of thanks to Afshan. You have presented very well. I'm sorry I was a little bit late because of the difference in the timing of prayers, but still enjoyed it a lot, and you have done a very good research work on the studies you have collected. Thank you very much, and please keep it up, and I look forward to joining your session next week, inshallah. Thank you very much.
Thank you. Thank you.
Sir,
For Dr. I'm sorry, who was the question before that? Dr. Makbul?
Yes, Dr. Makbul.
Okay. So the thing is, like you said, that why are we pushing fluids? I think it depends on the practice where you're working. And we push fluids according to the same indications that are given, which is neonatal hypotension, if it is proven, and the inability to start a neonatal heart. And that is when you start pushing fluids, and that is when you go into the panic mode. Really, this is not a forum to discuss which neonatal resuscitation protocol to use. All I'm saying is that the protocol should be based on local data and available expertise that can be made available in most centers that deal with such neonates.
So I think it is the time. There's any other question? I think there is one question online. Does every case of PBL develop cerebral palsy later in life, Dr. Afshan?
No. Not every case of PBL develops cerebral palsy, but they do need follow-up by pediatric neurologists, and they do need anticipatory guidance for the parents, especially when they enter school. And this I'm going to cover in the next session, inshallah. Outcomes of PBL.
Sure.
Right. Sir, next week is Eid. So, inshallah, madam के दो sessions हैं. One is जो अभी हमने जो है वो online था. Second session madam का था next week. तो next week is Eid. तो हम 8 जुलाई को रख लें उसके बाद.
Okay, that's fine. Perfect.
Comfortable for you?
Dr. Sajjad?
Yes, please. Hello. Yes, please.
Yeah, I can hear you.
Yes. No, I have just said my thank you already.
Yeah.
Okay.
Thank you very much. Thank you.
I know
Appreciate it.
Saeed is asking about after the Eid session. I think, yeah, that's fine. 8th of July is fine, not on the next Saturday because of the Eid holidays and all this stuff. So I think that's perfectly all right.
So, sir, inshallah, next session of madam.
One more thing before you go, there is one question by Danish. What is the role of cardiovascular care in neuroprotection in preterms? Yes, there is a role.
Yeah, it has a role. I will cover it in the next session because, like
Sure.
I said, that evaluation and management, I just needed to describe the problem before I go into the evaluation and management. So we will discuss it.
Okay. So that's all from my side, Saeed.
Yeah, thank you very much, madam. Truly speaking, it was very nice presentation. It was very informative. So once again, thank you so much, madam. And inshallah, our next session will be after Eid with continuity of the same brain injuries in the preterm babies. So thank you very much, Professor Khalid Haq and Dr. Junaid, Mohib Khan, Dr. Naveed Durrahman, and Sir Sajjad Rahman, all are who are with us in today's session. So till next session, Allah Hafiz and bye-bye.
Allah Hafiz.
Allah Hafiz.
Thank you.